It's been resistant to just about anything that has been tested in relapsing remitting disease. And the challenge has always been that if you handed the tissue from someone with progressive disease, if you showed imaging to someone with progressive disease and asked them to distinguish based on tissue, based on imaging, that this was a patient who had progressive MS from relapsing remitting, it would be impossible. And so is it a continuum from relapsing disease? Is the primary progressive form of this disease just a non-relapsing form of MS? And if so, then why is it not amenable to the treatments that we've used that seem to be successful at treating relapsing disease? It's a puzzle. And then we look at a couple of agents that have shown an ability to get at some aspect of what we think is going on in progressive disease. The fingolimod S1P receptor agonist, for instance, is an example of we know it gets into the central nervous system. We know it has effects not only on lymphocytes, but if you put it in an interaction with the brain and brain cells, it all is very positive, looks like it has a regenerative response, and even affects some of the important metrics like we've seen with brain atrophy. And you'll hear a follow-up of that INFORM study, which was reported earlier last year as being completely negative. Why is that? How is it that this same drug that looks like it should work had zero effect, even on what was thought to be the most sensitive indicator, brain atrophy, which it had a profound effect on in relapsing disease? So very puzzling. We've heard already from the ECTRIMS meeting on ocrelizumab, and we look forward to seeing the late-breaking discussion regarding which patients may have been the ones that are responding, because it's the first drug that actually broke the ice, we'll say, in primary progressive MS. And there'll be several, I think, discussions around B-cell directed therapies. People have had these for a while. And trying to understand that pathology. Is it a different pathology? I think the process of whatever it is that's contributing to this progressive nature of MS probably begins right at the beginning of the disease. And in relapsing remitting disease, it's overshadowed by relapses and MRI activity. And then as that fades away, you're just seeing this process now be more evident. Other people think that it's not there before, and it only starts. Your approach to treating that would be very different. If you knew it was there from the beginning, then here's where a lot of people are saying, well, if a drug like a B-cell directed therapy will work later, why wouldn't you want to start it earlier? At a time when that process maybe isn't so evident, but you know it's going on, as opposed to later when it may be too late to have its maximal effect. And so some of the data that we're seeing here is going to be directed at that. Well, I know the FDA is using whatever terms they have for fast tracking it. I mean, clearly an unmet need. You got a whole bunch of people out there with progressive disease who have absolutely nothing to take, and they've been having the gamut thrown at them, and some of them suffering toxicities which were needless because none of that stuff really works. If you look at the ocrelizumab data, it is positive, but it's not overwhelming. It's not clear which group of patients is benefiting. If it turns out that it's impossible to show a priori which group of patients really should be targeted with the therapy, we'll have no choice but to give it to everybody. The dilemma, I'm sure the regulatory people are going to face as well, is can we really separate secondary progressive MS from primary progressive? Everything you're going to hear at this meeting is going to try to marry those two, because really there's not a heck of a lot of difference between the two. And if that's the case, People are either going to suddenly become primary progressive in order to get the drug, you know the game, or our docs are going to use it off-label, so to speak, and give it to their secondary progressive patients, which only makes sense since we have nothing for them either. So it's a dilemma. The other dilemma is the toxicity, and I mentioned it at a symposium yesterday. This is real. They had a number of malignancies, and what crept up was all of these were breast cancer, and they were all in the ocrelizumab arm. So it's not just, if this was natural history and people get breast cancer, then why weren't there any in the rebep arm? They were all in the ocrelizumab arm. And so these are questions that need to be answered, and especially in progressive disease, the curve separated fairly quickly in the study. It was an event-driven study, so you needed to go 3 years plus. How long do we expose the patients to this drug? Are they on it for the rest of their life? Is this something that they only have to take for a few years? And there's lots of questions that need to be answered, and if you're going to embark on this therapy for your patients, can they live the rest of their life without their B cells? I don't think so. And you have to have some kind of a strategy to move on from.